panel on your dashboard. Today, we will start off with a high-level introduction to CAQH Core, followed by updates on our key projects, as well as time to answer your questions. As you can see from this agenda slide, we have a lot of information to share with you, so let's get started. I would like to introduce our first speaker, CAQH Core Managing Director Gwen Lowes. Gwen?
Good afternoon, everyone, and thank you for joining us. We're happy that you're on. I am going to just talk a little bit about, there's always some new people on these town hall calls, and we love to get new people involved and engaged and send them the way to the folks that have been working with us for a while. So I'm just going to give a quick overview about CAQH Core Mission and Vision for those that are not familiar with the mission and vision. And you can see this on slide 5. So our mission is driving the creation and adoption of healthcare operating rules to support standards, accelerate interoperability, and align administrative and clinical activities among providers, payers, and consumers. And just a note here, this concept of the mission aligning administrative and clinical starts becoming more and more important as we move into value-based, and also the role of the consumer. So as we're moving forward and we're thinking about how to fulfill our mission and the vision, we need to have a focus on those areas. There is a designation of core by HHS, and that occurred due to the Affordable Care Act. So we are an HHS designated operating rule entity, but we became into establishment prior to the ACA. So CORE started as a voluntary initiative, no regulation, because the industry felt it was so important to work together to collaborate and improve and simplify all the transactions that are needed for the back office. So no regulation, just industry effort to move forward. And there is a multi-stakeholder board, and there's voting members on that board. They're HIPAA covered entities, as well as advisors that are non-HIPAA covered entities, because both the implementers, so the health plans, the vendors, the providers that have to follow these operating rules, the underlying standards and all the policies, and that can get certified and can experience things like bad debt if things don't go well, they're essential to CORE, as are the advisors like the provider associations or the standard setting bodies. So all working together to fulfill the mission. And there is an integrated model. We do not promote just developing something and leaving it at the door for the industry to adopt. It's really been a development of what works as best practice. So if it has best practice in the industry and we can move it forward and really create a testing and certification platform, follow through with building education awareness, provide technical assistance, and you're going to hear about that. There's a lot of free education sessions and tools that CORE offers, promoting adoption, tracking the results, which you can see throughout the CAQH Core website, and then updating and maintaining. That is the whole integrated model. And there will be new things where when we're at the beginning of the development, you don't move to what we traditionally would call certification, but into a pilot testing where the industry is so new with something, they need to pilot test it and make sure it actually is a best practice the whole industry should work around, and that we should be developing operating rules and promoting the certification and testing in a more formalized way. So that is in the integrated model, and it's critical to meeting CORE's mission and vision that we think about the whole circle, not just one part of it. With the sphere of work, I already talked about CORE starting out as a voluntary initiative, and I just want to reemphasize that because that is the history of CORE, completely voluntary. And then when there was an HHS designation, we did apply for it and applied for it several times in a very formalized way. So that is a critical part of our role now, is meeting both the voluntary and the HHS designation. And across the board, both of those things need to deliver return on investment, value, and industry needs. So we don't do anything around CORE that's not going to have value and need. And you'll know if you are involved in some of the CORE work, taking all that criteria, whether it's the CORE guiding principles, it's board need on time frames, all those types of criteria and value, need, they all are relevant to anything that's produced and all applied throughout the process. We are now, which I'm sure everyone finds it hard to believe, today is the first day of summer. I think it's summer solstice. The days are getting really long, which is always fantastic. And it's the middle of the year, and so we just wanted to, we're going to spend a little time today about talking about what our goals were for 2017 and where we are, and also hear from you about what you're thinking about for 2018, because I'm sure many of you are in planning already about 2018. So we had 3 major areas for 2017. One was to serve as our federally recognized national operating rule author using the existing core integrated model. And you saw the model, and we take this role very seriously. We're completely committed to it. So we have been continuing to provide implementation support for the existing rules that are mandated, as well as the voluntary aspects of those rules. All the maintenance that is federally regulated, and you'll hear about that today. And then working with federal advisory committees, specifically NCVHS, which is the Federal Advisory Committee most relevant to this area. And then some additional things like the next version of the X12 standards as they come up, and what do we need to do as CAQH core to evaluate that process. The second goal is functioning as a voluntary certifier for operating rules and underlying standards. Again, core started as voluntary, and the development of all the requirements and the education, the outreach is so important, but the certification really takes it to another level, because entities are actually testing with an independent entity to see do they follow the rules, and they're sending their trading partners. And again, it's all voluntary, but you'll hear today about how we have moved forward, and that was a big goal that all the core participants and the board leading the way feels that certification is essential. The next one is to drive and pursue voluntary multi-stakeholder value. As we all know, some of the regulatory requirements are lessening for the role core has as the HHS designated author. So we had already planned out for 2017 some things that we were going to do in a voluntary manner. So for instance, driving through on phase 4 certification, some of the value-based payment works, the next stage of prior authorization that supports what's already in phase 4, and attachments, assuming we would want to move forward with attachments with or without any type of regulation. And then of course continuing to align and evolve, because we don't want to stay stationary. The world is changing, we need to change with it. So those are the main goals for the year. And I am going to give you an update about some of the value-based payment work, and then I'll hand it over to Bob Bowman to talk about the prior authorization work. And we'll walk through these different areas around this model. We're going to give you examples, do some polling questions, and then make sure we have time for Q&A. So value-based payments, if you look at slide 10, the core board really recognized the importance of all the back-end functions will be changing in the healthcare industry as we move from a fee-for-service environment to a value-based payment model. And when I say model, it's many models. I think all of you are probably experiencing there's multiple ways to have value-based payments. They're depending on where you are in the industry, geographically, by specialty, by contract, with payer where you work with, how much you work with Medicare. The amount of value-based payments varies, and anywhere between 30 to 50%, and in some instances, some providers and payers are doing none. So this is just an average. We are expecting by 2020 that we'll really be moving into half, and so we want to plan for that. And there'll be across the board the need to improve operations and collaborate on those operations to support the success of value-based payments. As you think about fee-for-service, we kind of caught up as an industry to pick up the pieces and figure out how to collaborate. We want to, with value-based payments, think ahead of the game and be identifying places where it makes more sense to collaborate and things and have operations that are common across the board and available to make this process of transition successful. Get ahead of the game. And so we have in 2016 conducted significant secondary and primary research, and now we're wrapping that up and we'll be moving to more of an execution phase. So just going to talk through that. You'll see on the next slide some of the secondary research. There's quite a lot, as you've all probably been reading about, published about the move from fee-for-service to value-based, and it's all over the spectrum, depending on who you speak to, how they define what program they're in, value dates, where they focus. You know, you're in California, you're talking capitation, and in with certain other areas. In other places, you really are talking a one-sided share program. So we are calling all of that value-based, and we did do that research. We identified some potential areas where CORE could take action, again, streamlining the administrative processes, the operations, so it complements the CAQH core mission and vision. Then we did primary research, conducted about 20 multi-stakeholders interviews, and there was a whole bunch of different structures involved, market types, geographical diversity, the duration of the VBP, including some entities that were not successful in executing their contracts, and then surveyed the participants about some of the results, and then came back and refined the list, did more secondary research, and had an external firm that has a number of consultants out in the market, Navigant, in really reviewing the results to see if they were on target. So we're now moving to, and you'll see on the next slide, a place where we have identified really 5 areas where there's some high interest, strong interest, and then lower interest. And I'm just going to talk high level about this. Common data sets would be right along the lines of other things you've seen within CAQH core. Provider and patient attribution is something that's evolving within value-based, sometimes more important with certain structures than others. And then patient risk stratification, that's a complicated process, and there's a lot published on it. And there's different models that entities are following, or they're using a model that's published. There's about 9 ones out in the market that then are being adopted and evolved and kind of tailored to different situations. Then there's infrastructure, interoperability, and best practices, and of course the quality. The quality was not seen as a high-level piece because there's already so many entities that are out there working on quality, and we need to build the collective consciousness of the industry about how important those efforts are, and that's part of what we'll be doing. You'll see in Q3 and Q4 is having some education sessions on entities that are already committed to the quality measures and the metrics. So you, as some of the CAQH core partners and participants and those that we work with are aware of those efforts. So for each of these areas, the report we have worked through identifies very detailed options to really bring some clarity into the market. And these are primarily cascading options, such as studying, is the national provider identifier, it's already a requirement, how actually often is it being used, and if it's mixed, is there an appropriate role to start checking that or reporting on it in a more aggregated way? What provider data elements are needed for attribution, and would you want to pilot those data sets? So these all are examples. Or over on the right, infrastructure and interoperability, there are the reporting and timeliness of certain data, such as claims, may vary a lot across the market, and that's becoming much more important to have a expectation about how fast such information comes. And maybe there are requirements that the industry wants to pilot and define to see if there's a need in the industry. And again, we're not talking about moving right to operating rules at all. This is all about research and what do we as a market want to define in a common way. So as we move forward, we are taking all these detailed options and evaluating them on the ability to accomplish. You know, is it high, medium, low, hard, difficult, easy, and then impact to industry. And again, I want to emphasize this is evolving. Piloting will be absolutely essential. This is not something we can look to where in the past there's been 3 or 4 states that have already shown us the path and we need to just start propagating it across the country. This will be new and the selection and the studying will be really important. So if we move to the next slide, you'll be seeing in the coming weeks, there'll be a CAQH core final report on this. There will be a core task group that is launched, and they'll be picking out some cascading projects that can be accomplished in year 1 and year 2 and setting out their goals. Again, recognizing the evolving nature of VBP and probably forming some tiger teams that will be focused on the different projects that are selected because the expertise will be essential to have at the right topic depending on the project. And you'll see over on the right, education will be just as essential. The research and the outreach, the surveying, the secondary reports, all the interviews, the data we collected, it all showed there's a real need to share more research in this area so we can all find our way as to how we want to work together. So we'll be putting emphasis on that. And we'll look to you for ideas. So with that, I'm going to hand it over to Bob to talk about prior authorization. I just want to, before I sign off here, I want to thank everyone again for coming on. We want to hear from you on the polling questions, want to hear from you offline. If you think there's things CORE should be doing or you want us to do more of or less of, please let us know. We want to hear from the industry. As we move into a focus on some of these voluntary works, it's even more and more important that you all are engaged. Thank you. Bob?
Great, thanks, Gwen. And just as Gwen mentioned, we do want to continue to share with you what we're doing this year and where we're going, and actually what we've done with prior authorization to date. So really with the vision of prior authorization is to increase the electronic prior authorization adoption by automating manual processes that reduce administrative burden on the provider as well as health plans and ensures that we enhance timely delivery of patient care. So on the next slide, you'll see that as we move through and try to accomplish that vision, there's very specific actions that we're taking. And that action includes, for this year, to evaluate the impact of additional voluntary prior authorization operating rules and other potential initiatives that further support that particular vision. I'm sorry, I might have a delay in these slides. I'm only showing the header, so we'll resolve that technical difficulty, but I'm going to continue on with providing the update for prior authorization. Again, because the initial launch with phase 4 on the 278, the prior authorization transaction, that initially set the foundation for the work that we're doing. And there are other issues and things that we need to consider as we move forward throughout this year for any potential operating roles. That includes the experience of both health plans and vendor products, both the successes and challenges that we face with PA. Also, the recommendation from NCVHS for additional PA operating roles that they outlined in a letter to HHS. So we're taking that very seriously as we move forward with potential operating role opportunities. We're also looking at what the industry is doing on this particular topic, and there's a lot of activity. The AMA issued a PA principles piece. The principles do have crossover with some of the work that we're doing currently, as well as what we're looking to do with this next set of potential operating roles. So you'll learn also from what the EPA adoption has done for the pharmacy sector. We're looking at, again, the lessons learned, the implementation processes that are going on for that particular transaction in pharmacy. And one thing that's also really important for us too is the criteria of what can we actually accomplish this and when can we accomplish it. So we try to be very thoughtful about how much can we as an industry kind of bite off and accomplish within a timed process so we can ensure that we do progress and make progress on a really challenging topic like PA. On the next slide, as I mentioned, stage 1, which was accomplished under the phase 4 operating rule set, really just laid the foundation for the particular technical requirements for the infrastructure of the transaction. So we allowed very specific things within that rule. For example, we'll in just a moment. Connectivity, companion guides. There's very specific things to ensure that the transaction and trading partners, their roles and responsibilities are known. Now with stage 2 that's in progress now, we're looking at the additional opportunities, trying to identify where we can move forward with PA and referral. Again, the advisory group is working on finalizing those particular opportunity areas to launch a subgroup in the third quarter. If we move to the next slide, you'll see exactly what stage 1 has accomplished. And it really is setting, again, that initial foundation for the operating rules. Again, this includes processing modes, response times, acknowledgments, connectivity and security, system availability, and companion guides. This is what the industry can adopt now to ensure that we can move the needle on the adoption rates for prior authorization, because the index has this at 18%. So it's a HIPAA-mandated transaction, not a lot of adoption across the industry. If we move to the next slide, you'll see that really our progress to date on our timeline. So in 2016, with the first 2 steps being accomplished of developing the initial draft of opportunity areas, fielding an advisory group to review and revise those opportunity areas. Moving into 2017, we conducted a 4-part environmental scan, which we'll go over some of that in just a moment. That helped really produce a set of findings that we can use and look at between the draft opportunity areas and the findings. What is that matrix? Where are the touch points? Where are the challenges, most challenging components for a provider and a health plan in conducting this transaction and conducting this business process? Step 4 is going on right now with the advisory group, and they're really applying the application of specific criteria to ensure that those opportunity areas that rise to the top, they are accomplishable, they are certifiable. There are things that, as we mentioned through our integrated process, there's things that we can actually accomplish within a specific time frame through the phase and ensure that the industry can adopt it. So with that, we'll launch the PA subgroup a little bit later this year. Moving on to the next slide, we do want to provide you some of the detail from the draft opportunity areas. And really they fall into 5 categories. Those include data content, workflows, formats, transport, and utilities. And within each of those, there's 1, 2, or 3, a handful of different opportunity areas that apply to that particular category. Don't go into a lot of detail here, but it's safe to say that we looked at everything from the data content of the transactions to particular far-ranging utilities to process the transactions to provider and health plan workflows, really looking at every component of the transaction, of the process that a provider takes and a health plan takes to submit, to adjudicate, to finalize, to notify the provider. All of those components are part of this environmental scan and fall into these categories. Speaking of the environmental scan, on the next slide are the 4 steps of the environmental scan that we can accomplish. The first is the participant survey. So many of you on the call may be core participants. You participated in that survey earlier this year. We had 76 respondents. They all ranked and rated each of the opportunity areas, both by category as well as by specific opportunity area, and had lots of comments. I think it was the most comments that we've ever received on any survey that CAQH Core has issued to date, with hundreds of comments coming in. So it's very, very helpful. The next was the multi-stakeholder interviews. We conducted interviews across the industry, both providers and health plans and software vendors, to understand particularly what their barriers are for this particular transaction, but also what are the opportunities, where have they seen success to date. We've also conducted provider site visits across the country, visiting provider sites, looking at exactly the resources that they use, the applications they use, the process that they have in initiating the prior authorization, submitting it, obtaining a response, and notifying the member that the PA has been approved. What does that look like from soup to nuts? And we've done that with 4 provider site visits, again, from large providers to small providers all over the place, to make sure that we really understand those components. Lastly, we conducted a vendor product assessment. We looked at 12 different vendor products and what they have to offer in the marketplace for both provider-facing, health plan-facing, and if they have products that support both. We looked at a cross-mix of those types of vendors, both regional, large, and national, to ensure that we understand exactly what the vendor products are doing, how they're using particular attachment types and standards, how they're submitting the transaction, what health plans that they're involved with. So all of that is part of that environmental scan that we've completed. From that scan on the next slide, you'll see an entire list of findings, and these are key findings from each of the four components of the environmental scan. So from the survey to the site visits to the vendor assessment, there's a specific findings that we found that are really important to the process of the prior authorization transaction and that business function that occurs between a health plan and a provider. So these findings, again, will help us determine the next steps for the opportunity areas. Again, we're pushing these up against the opportunity areas as a matrix and understanding exactly what those touch points are, doing an assessment, and ensures that which ones can we actually accomplish in a time frame that is meaningful to the industry. So all of that said, on the next slide, where it really is a call to action for anyone that wishes to be engaged in prior authorization and the work that we're doing here at CAQH Core, we're going to be launching that subgroup later this year, hopefully in August. So it's right around the corner, actually, if it's already the summer solstice. So we need to make sure that if you want to be part of that process, that you are engaged. So please reach out to us. You can contact us through our website or through email to let us know that you want to be part of that core participant group that is going to be working on prior authorization this summer. With that, I'll hand the call back over to Jessica for our first polling question.
And Bob, this is Gwen. I just wanted to add, as we think about the next steps with this, we are going to have a core participant exclusive webinar on the 27th to drill down at some of these findings. And then also launching this subgroup, and you can see email core@caqh.org. If you are a core participant and you're on and you want to join, make sure you email us and you sign up for this group. And I also wanted to highlight, we mentioned that there is a multi-stakeholder core board earlier. One of the board members, Dr. Barbara McElhaney, is actually a practicing physician, and she's an oncologist in New Mexico. And prior auth is obviously a critical issue for her area. And, you know, she did volunteer to have her office site visit. But more importantly, you know, for the last 2 years as she served on the core board, she's been highlighting to all the other board members how important this issue is to providers. And we have done an overlay of the recently issued AMA 21 principles on prior auth with core, and there's about 7 areas where there is overlay. And Barbara was just elected as chair-elect for the AMA board, so we're very excited, but she is reminding us on a regular basis about how we need to make progress in this area, and that phase 4 is a fantastic first step. And then we always saw this as an iterative process. You'll see that in the letters that CORE wrote to NCVHS. So we need to keep that iteration going. There is no silver bullet here, and we need to, as an industry, take and move with each of these items to solve this process.
Thank you, Gwen, and thank you, Bob, for setting up the first polling question for me. As you can see on the slide, the first polling questions is trying to gauge your interest in becoming part of the CAQH Core prior authorization subgroup. And during this polling question, while we do want to gauge the interest of this audience, so we would like all of you to respond to this question, I do want to point out that if you actually do want to be part of this group, you need to be a CAQH Core participant. So for those of you who are not, hopefully this is an incentive to join us. So the question is, are you interested in becoming part of the CAQH Core prior authorization group? And let's start the poll. And the answers are yes, no, and unsure or need more information. We're going to give you a couple more seconds to respond. Maybe 5 more seconds. And then we'll share the results. So let's close the poll and share the results. So as you can see, the largest number we had was the unsure, need more information, and we will definitely follow up with those of you who answered that way. And then the second, and 28% of you said yes. So we will also follow up with you that responded that way.
Jessica, this is Gwen. I just want to, for those of you that are unsure, we would love to hear from you, or that don't want to do it, why, and what else are you doing to solve this really important issue. We want to make sure we're hearing from everyone. So again, you can email at core@caqh.org and ask for someone from the staff, or there is an advisory group that's multi-stakeholder that's been working on this. They would obviously love to hear this information as well, because they're all implementers and committed to moving ahead. So do reach out. That would be very helpful. Thank you.
Thank you, Gwen. So now let's continue the program with a presentation on our work on attachments. So Bob, take it away.
Great, thanks, Jessica. We do have just a couple slides we want to provide as a way of update for the work that we're doing on attachments. So on the next slide, you'll see that we are ensuring that the work that we do does align with the mission and goals of CORE. We know that electronic attachments would ease the workflow within our healthcare system. The lack of electronic attachment standards is definitely a challenge for both providers and health plans, and vendors even for that matter. We are committed to providing guidance with or without a mandate from the federal government on attachments. Again, there's been few regulations in this area. We know that the initial HIPAA regulation did call for a claim attachment standard almost 20 years ago, and that the ACA, Section 1104, does require the Secretary of HHS to adopt a standard and applicable operating rules for the health claim attachment transaction. So to date, that has not occurred. However, the industry has making steps in different directions that we definitely need to make sure that we all understand. Again, there's been some regulatory activity on the clinical focused attachments, but little or no action on the administrative side. We know that claims attachments work is being moved forward by HL7. However, there's a wide range of opinions on what standards would serve the industry best regarding electronic attachments. And some of that findings from the CAQH index report for 2016 are pretty persuasive in understanding that there is a wide range of options out there. If we go to the next slide, the report did look at 5.4 billion different transactions. It reported on both the adoption and the cost of electronic claims attachment transactions for the very first time. Found that only 6% of the claim attachments are submitted to health plans electronically. All the rest are through fax and mail. 100% are submitted manually. Every plan accepts manually submitted claims attachments. In labor alone, over $1 billion could be saved by the industry by fully adopting electronic claims attachment standards and process and operating rules. Participating health plans did self-report only the use of X12 standards for claims attachments to date. For the ones that participated in the report, that's all they're using for the attachment standard for claims specifically. Again, there's a wide range of opinions. It is important to note that HHS's Meaningful Use Program requires EHRs to use the HL7 standard for clinical attachments. Again, there's been no authoritative benchmark data available on that adoption of the EHRs for the HL7 standard. So there's the requirement, but we don't understand exactly how broad that is, what the volumes are, what the adoption rates are, and what that means for us as an industry, especially as we look at this on the administrative side. If we go to the next slide, there's definitely the continued need for education on attachments within the industry. And so we are partnering with experts within the industry, particularly on attachments, and hosting a series of webinars. We've completed 2 today, one for the foundations of the electronic attachments, and the other one was specific around claims attachment pilots and production implementations. So you have a wide range of use cases and case studies. So again, these are really going to be important as we move forward. Again, these are just the first 2 in a set of series of webinars that we're going to be conducting this year. If we move to the next slide, you'll see that it's going to be really important for the industry to consider case studies and production projects that have gone on throughout the industry. And these are just some examples that are important because they actually provide a wide variety of data, from the use of PDF to something as complex as the CCDA, or to unstructured data for the 275 version 6020. So lots of numbers, not to confuse anyone, but there's lots of variety, lots of different options, and everyone is taking an approach because it's so important to get paper-based claims attachments into an electronic format and get it moved electronically from the providers to the health plan to ensure that claims adjudication is not negatively impacted. So again, multiple efforts, lots of things moving on. The industry is approaching electronic attachments in a variety of ways, and we're trying to collect as much information. We were going to be looking at more and additional case studies to ensure that the range of standards, the workflows, the implementation are all driving to a successful implementation, because we have to make sure that the ROI is really there. With that, I'll hand the call back over to Jessica for our second polling question. Jessica?
Thank you, Bob. So our next polling question, as Bob just mentioned, we're holding an attachment series, and we want to hear from you what you would like to see covered in the next webinar or two in our series. So as you can see here, we have 4 options, 3 options and another, and if there's another topic that you'd like to see, we'd like you to include it in the comments or questions section. So let's begin this poll. And we're going to give you a few seconds to let me know whether you'd like to hear about more case study pilots and implementations, whether you'd like to see some, some technical dive webinars or something else. So let's give you 5 more seconds, and then we will share the results. So let's share the results. And it's actually pretty close here, but it looks like you guys want to hear more about case studies, followed by some more technical webinars, and then the third is a mix of healthcare and industry neutral standards. So given that, I think I know what I'm going to be doing on attachments for the next few quarters. So with that, our next presentation is an update on voluntary course certification, as well as the CAQH core enforcement policy. And this presentation will be by core manager Taha Anjarwalla. Taha?
Thanks, Jessica. So today, again, my name is Taha Anjarwalla. I'm the manager of course certification at CORE, and today I'll be walking through the core certification program. So as a program, voluntary course certification is really the gold standard in how a certification program should be developed and administered. So this slide outlines the various elements that make up kind of check and balances that make the voluntary certification program unique. And I'll touch base and dive more into each of these elements throughout the presentation. So next slide. So moving onto this slide, we're happy to announce that a total of 320 course seals have been issued by CORE, with the most recent certifications including Boston Medical Center Health Net Plan, Cal Optima, which is a Medi-Cal plan, and 2 federal employee benefits plans, including the National Association of Letter Carriers Health Plan and Government Employee Health Association. And then looking at the impact that core certification has on the nation's healthcare system and measuring the amount of covered lives that benefit from core certification. For phases 1 and 2, which cover the eligibility and claim status operating rules, about 76% of the commercially insured and 44% of the publicly insured are covered by a core certified health plan. And for phase 3, we can see adoption is growing, with about 27% of the commercially insured and 25% of the publicly insured are covered by certified plans. So there's definitely a lot more work that needs to be done there, but we're seeing trends in growing adoption with phase 3. Moving to the next slide. So this slide helps illustrate the different components and kind of the life cycle of the certification program. So as organizations go through the certification process, the first step is to commit to certification with the signing of a core pledge. The pledge helps formally help organizations commit to certification kind of at that executive level, and help also communicate publicly that the organization is committing with implementation of the operating rules. Next, organizations are required to go through a testing and application process where testing is conducted by a third-party testing vendor that is authorized by CORE to help ensure an independent validation of conformance testing with the operating rules. After testing, CORE serves as a neutral administrator that reviews and approves testing results and conducts additional screening prior to awarding a CORE seal. So certification does not end with awarding a seal. Certification has a certification enforcement policy to help ensure the industry is proactively self-monitoring and self-reporting itself when CORE certified organizations are non-compliant with the operating rules. This enforcement policy helps to create a check and balance system to help reinforce that the CORE seal represents value, trust, and achievement of certification, a true gold standard. So moving on to the next slide. So I wanted to highlight that organizations can now test for phase 4 certification, and we do actually have several entities currently testing for those transactions related to claims, prior authorization, enrollment, and premium payment. These organizations include health plans such as Humana, Texas Medicaid, and Dakota Care, and vendors like PocketDoc. Jumping on board and participating in phase 4 certification early allows your organization to establish itself as a leader in the industry and as an early adopter, as well as drive more value as you may already have the foundational infrastructure for phase 4 from implementation of prior phases. So next slide. So next up, I'll be kind of talking more about the enforcement policy that I briefly mentioned earlier. So as part of our one of our outreach efforts for this year, we're working to build industry awareness on the existing certification enforcement policy. As a component of certification, the enforcement policy has always existed, and CORE certified entities must adhere to these certification policies in addition to implementing operating rules and going through testing in order to become CORE certified. The enforcement policy helps applies to certified entities, including not only just health plans, but vendors, clearinghouses, and providers. So anyone that is CORE certified, the enforcement policy applies to. Similar to the operating rules, the certification, the policy was developed and approved by CORE participants, highlighting that the policy was also developed for industry by industry. Further, the policy also follows a complaint-driven and collaborative process with the focus on remediating issues of noncompliance versus issuing penalties. The enforcement policy helps benefit the industry by taking a self-policing and self-reporting approach, empowering the industry to ensure they are able to receive and maximize the benefits afforded by the operating rules. This approach allows the industry to allow end-to-end monitoring of the conformance across training partners and helps to identify gaps within the systems.
Taha, this is great news that we're moving forward with this. For those entities that are on the phone that serve providers, if you think about the commercially insured covered by the certifications, every provider working with those health plans should be getting the information. And so we're going to need to really find out if they're not, is it the practice management, the clearinghouses, is the provider not aware of how to get the information? And so we're looking forward to how the industry can use some of the tools that will be coming out on this to see why the end-to-end may or may not be working. Because we know the source of the data now. We're getting a lot of coverage. So this is a great time for this awareness campaign.
And with that, it's time to do our third polling question. And what we want to do with this question is, you know, we've talked about the enforcement policy and how this is something that we're going to be educating more and more on, but we want to kind of see where you guys are. So what is your level of awareness of this enforcement policy? Are you very aware, not sure, but would like to learn more? Do you have questions about it, or you didn't know? So please, let's start the poll, and let's see where our audience is on this topic. So let's take 5 more seconds, and then we will show the results. Okay, let's see where we are. And my goodness, we are evenly split between being very aware, not sure, and not knowing about the enforcement policy. So you guys do not make it easy on us here in the education and outreach part of CORE. So we have a lot of work to do. We are happy that a third of you are very aware, but for the rest of you, we are going to be reaching out to you with more and more education. So for our next presentation, we will get an update on our Phase 3 maintenance activities, once again by Bob Bowman. Bob?
Great, thanks, Jessica. And as Jessica mentioned, we do want to provide you with an update of what we've been doing year to date with our maintenance process. If we move to the next slide, you'll see that we have been working on the core code combinations for this year. And really the code combinations task group takes inputs from either when the standard code lists are updated or through our annual, once per year, industry business needs, our market-based review. So the CBR, the compliance-based review, is 3 times per year. The MBR is 1 time per year. And that impacts each of the 4 core business scenarios, which again is the scenario that's used to ensure that the provider understands exactly why a claim or a claim line was adjusted or denied. And we have these 4 different buckets, these 4 scenarios that really constitute about 80% of the problems that providers have had in the past when understanding exactly what that result of the adjudication was. On the next slide, you'll see that the work that we've done to date, we just published on June 1st, 2017, the latest version of the core code combinations. There were 58 adjustments in total with 8 new codes. 49 codes were modified and 1 code combination was removed. Again, we're really is not much of a way of movement, right? Not a lot of adjustments, only a handful of codes were added and 1 was removed. So we're thinking that this is really showing that the code combinations are meeting the business needs of the industry, because this does include the work from both the CBR and the combined MBR together. We only had 58 adjustments. So again, we're looking at using multiple vehicles, again, looking for outreach across the industry, particularly with providers, to ensure that they understand the code combinations that are coming in from health plans, that they understand what the impact that they're having when they have to go back and do second billing. They have to understand, they have write-off, do they actually, are they sure that they understand the meaning of the code combinations that they're receiving. On the next slide, you'll see that we will also be launching later this year the EFT and ERA enrollment data set maintenance process. Again, the goal here is to ensure that we can incorporate any lessons learned from the increase of EFT and ERA enrollments to date and address the emerging, new, or changing business needs related to the data set. So again, we do a comprehensive review this fall, and we do have limited reviews. The next will be scheduled for 2018. We alternate years here to ensure that we're, again, checking the industry on what we need for this particular data set, because things do change. We have to make sure that we have a maintenance process established and in place and can adopt to those changes. So if you are curious in helping us with these efforts, on the next slide, again, these are industry-wide initiatives, both for the core code combinations with the CARCs and RARCs and group codes, as well as with the EFT and ERA and enrollment data sets. If you are interested in working on either of these groups, again, feel free to reach out to us. We'll be launching both of these again this year to handle the next CBR as well as the future MBR. With that, I'll hand the call back over to Gwen for our next topic. Gwen?
Great, thanks, Bob. So just a few things on federal mandates. Obviously that we know there'll probably be a bit of a delay with regulations, but NCVHS, which is the Federal Advisory Committee, the FACA, that works with CMS, is meeting, and they're discussing certain things, and they are writing letters to HHS. They did already hold a hearing and specifically asked for testimony this year, and we provided it in May of this year on the health plan identifier. Some of you may know the history of the health plan identifier. It's up here, and that there was a regulation and there was a delay. Now they're asking for feedback, and there were 2 purposes. One was to put the HPID in the transaction, and the other one was for other legal purposes. And so based upon core board letter issued a bit ago, another core board discussion, as well as an open call with core participants that we had very good attendance at and a lot of discussion. Core did issue testimony and to not require the HPID in the transactions because the routing world has changed so much. And if there are other legal purposes such as certification, that there should be a clear business purpose issued by HHS and a number of other criteria, that they have the absolute ability and right to do that, but outlining it for the industry so they can respond. Another piece with NCVHS is a predictability roadmap. They had called for this in kind of the mid-2006 about some predictability on timing for when operating rules and standards would come out. And they're starting to have different steps to dig into a process to then issue a recommendation sometime this year and a letter to the Secretary on predictability. And CORE is participating in this as well as standard setting bodies, both answering questions, submitting documents. There'll be a day-long session and then some testimony and review of documents. So stay tuned, and we will obviously update you on our activities in this area, and we're actively committed to supporting NCVHS's work. Bob, I'll hand it to you.
Great, thanks, Gwen. We do want to provide another quick update for you on the 7030. If we can go to the next slide, you'll see that X12 has released for public review the version 7030 Type 3 technical reports for the TR3 documents. These are really the next major release of the electronic healthcare administrative transaction standards for the industry to consider for adoption, right? So X12 has stated its intention to propose these version of the TR3s be adopted as the next generation of the transactions for HIPAA. If you move to the next slide, you'll see that there have been a number of cycles that have already occurred. So 1 through 4 have already been complete. Beginning September 1st through November 30th is going to be cycle 5 and 6, particularly important for CAQH Core because of the operating rules that we have related to data content for the eligibility transaction, and as we look as the industry for operating rules around the 278 or the prior authorization transaction. So there's going to be some work to be done for this particular TR3 review process the Core has in mind for later this summer and into the fall. If we move to the next slide, to ensure that we have just a few minutes for questions perhaps, we do want to highlight that for each of the cycles there are particular transactions and there are particular operating rule phases matching with each of those transactions. Again, the more important here for us is this next cycle that's going to begin later this summer with cycles 5 and 6 for the eligibility and the 278 or the prior authorization transaction. But again, every previous cycle there is an operating rule, particularly for phase 4, for the infrastructure requirements, for the enrollment, the premium payment, all 3 versions of the claim transaction. Those are all really important, especially for the 278. Again, setting down that foundational requirements for infrastructure is really important. So that is all in the past, and we're going to be looking forward to the next cycle that's going to begin. And we do have a milestone approach, if we can go to the next slide, that we're going to be taking as we review these TR3s, and that will include both a notification to the core participants beginning on September 1st when the TR3s are released. We're going to look at milestone number 2 to the development of the draft core rule comments, core comments. We're going to be reviewing the TR3s, drafting particular comments around 3 focus areas, in particular for core, that is return on investment, data content, and any maintenance processes that are defined or not defined within the TR3. Lastly, milestone number 3, we're going to ensure that we get feedback from the core participants on a core participant only call. We'll be sharing our findings on looking for comments from the core participants and gathering that information. We'll also seek other information from core participants if they wish to provide that comments and feedback offline. So you don't have to attend the call to provide the feedback. We'll also have a formal process to ensure that you can submit feedback to us. Lastly, we'll revise all the draft comments and integrate that feedback from the core participants, hold that second core participant call if we need to, and lastly, we'll submit any comments that we receive to X12 on the 2 TR3s, again, the TR3 for the eligibility transaction and for the prior authorization transaction. And with that, I'll hand the call over to Jessica for our final polling question. Jessica?
Thank you, Bob. So I'm going to take this last polling question as quickly as possible so we have some time for Q&A. So for this last question, what we're looking for is some feedback to see what we should be working on next. So take a look at this question, what needs to be prioritized by us in the future? Is it tracking adoption of existing, further defining crossover between fee-for-service and value-based, continuing our work on certification and enforcement, or other? And this is a select all that applies. So let's launch this poll and give it a couple of seconds, and let's see what you guys, what the audience tells us. So we're going to give this 5 more seconds, and then we will share the results. So it looks like there are two strong responses. One is track adoption of existing and publish process for future, and then the other is further defining this crossover between fee-for-service and value-based. So this is very good feedback to hear from you, and it will help guide our efforts. So now let's take a couple questions, and we really do enjoy sharing our information with you, so my apologies for not giving enough time for Q&A. So I did see one question come in asking about the prior authorization. And the question is, has anyone brought up the issue with PAs that the 278 is not adequate in terms of the amount of information on it to actually do a review for the authorization? So Gwen or Bob, do you have any comments or feedback on this question?
And Gwen, I'll jump in. I know we're short on time, but a lot of the feedback that we've had both from providers and health plans and the software vendors that we did the vendor assessment with, all of the components, 6 months worth of work on the environmental scan, basically, there was not a lot of feedback on the lack of detail or the lack of the data within the transaction. A lot of the feedback was more related to does the provider actually submit all of the appropriate data from the health plan perspective, and then if the provider is submitting all of the data that is required to initiate a PA, what is the holdup or the roadblocks in actually achieving the kind of like a real-time adjudication or adjudication within a time frame that supports the physician and member interaction and ensure that the member receives care within a time frame. Because there seems to be that gap between the provider has the data, the health plan may not receive it all. When they send in the data, when the health plan receives the data, do they need extra clinical documentation? Do they need attachments? Sending back the request, obtaining that information from the provider. It's all very much a manual process today. There's no auto adjudication. There's no way to electronically submit the attachments in a way that's conducive for the provider and the health plan. It's all manual steps every step along the way.
And I think, Bob, one other thing that the advisory group's been speaking about is what are the things that the X12 transaction can do, and what are the things that would need to happen outside of that transaction to work on the data content, and looking at both of those options because there's different ways to go about the problem, and that's why it's so important for those of you that are on the phone. And some of you may do part of the prior auth with the X12 transaction. Some of you may have luck and more success with other methods, that as we look at the options for additional operating rules, bringing your perspectives into that subgroup.
Thank you, Gwen, and thank you, Bob. And for our last question, we got a question that came in on the ERAs and the code combinations. So Bob, what do we say to the people that are still out there and they're still facing some challenges with the code combinations? So many are seeing benefits, but what do we say for those that are still struggling?
It's a great question. I think that one thing that entities or folks, providers can do if they're still struggling with the code combinations is to ensure that they're working with their health plans and understand exactly what the health plan is trying to do. A lot of times this requires that manual intervention. They're calling the health plan. One thing they can do is to bring those types of issues to CORE or to the codes committees. If the code doesn't make any sense, the language within the code, that's something probably that the code committee should address. But if it's a combination that is a mismatch, is it a core code combination? We can help you identify if it is or if it isn't. If it is, we can work with our larger body of the task group, which includes representatives from all the core participating organizations. We generally have over 50 people, over 50 organizations that attend the calls. We have very active participants, both from provider organizations as well as plans and health plan associations. They're looking and scrutinizing these really to the nth degree, from this code means this and this code means this, and together it should tell this to the provider, and this provides this action for the provider today to take. So if the providers are having problems with that type of information coming in and they don't know what action to take, then the code combination is not really doing its job, and we can help the provider and the code committees and the core task group understand that this particular code combination is not helpful, and what can we do to adjust it, to make it change to it.
And Bob, this is Gwen. I want to add two other thoughts to that. Another avenue too is there is core certification, so you want to look and see, are your entities core certified? If they're not, getting them certified, because that's part of the testing and the process is to use the combinations. And then additionally, the group looks at real-world data. They actually collect real-world data and then analyze it to see what the results are if the combinations are being used. If any of you that are on the phone and your organizations that have aggregated, obviously, non-PHI, we want clean data, and we like to submit data from your clients, from your source if you're a health plan, to show what the adoption and if there's any variance, we would welcome that. The ongoing task group that works on this does ask for that type of data, and we are considering under the existing budget if we can do a more extensive study on what the results are here, because data is always most informative when it's large volume and an aggregate like we're seeing with the index. So thank you. Jessica?
Thanks, Gwen, and thanks, Bob. And so on the next slide, you'll see our work broken down by project area, and Gwen just mentioned, some of the actions that we're taking on the code combinations. And what I'd like to point out is all those places there that say action are things that you can do right now to get more informed and more engaged, and things that say core participants are for obviously core participants only. And so on the next slide, it's just here are the next webinars in the next couple months. We hope you'll join us. And finally, thank you for joining us. A recording of the session will be available on our website in the next 24 hours, and we'll also send you a copy of the slides and the recording when it's ready. You may now disconnect and have a great rest of your day.